Hello, beautiful people. This is Dr. Lindsey Matthews, your BirthFit founder and CEO. Today is episode 266, and we're going to be talking about dilation and effacement. A couple episodes ago, we started talking about grading tools used in labor or progress tools, and I mentioned station grading and Friedman's curve. And now we're going to talk about the big elephants in the room, dilation and effacement. Before we jump in, I want to share with you that you need to check out our website. Right now, so hopefully it's up by the time you hear this. Right now, our website is under construction, getting a whole new facelift, and we are updating our website to be more in alignment with our new mission statement, which in short means we are training, we are leading the leaders, we are coaching the coaches, we are educating and empowering coaches and practitioners to lead women inside of their communities, to lead women back into their own rhythms, resiliency, and sovereignty inside of the motherhood transition. As soon as the website's fully up and running and our directory is rocking, be sure, y'all, our directory is getting a facelift and I cannot wait for this. But as soon as it's up, I will have a podcast episode dedicated solely to that. So that means that our BirthFit certification waitlist will be open then, and we are accepting people for the waitlist for the fall cohort. The BirthFit certification is formerly known as the Coach course. It is, which is formerly known as the Coach Seminar. That was our live version. Then when we had to move everything online in 2020, it became the Coach course. And now BirthFit certification. And I'll elaborate on this in the future as well. But mainly because inside of each cohort, there's not only coaches and personal trainers, but there are chiropractors, there's physical therapists, there's midwives, there's OBs, there's acupuncturists, naturopaths, osteopaths. There's an array of practitioners in there, y'all. And this is amazing. Why? Because on the other side of the BirthFit certification, you learn how to be in relationship with all the other practitioners in your community, all the other coaches, all the other people that are serving women inside of the motherhood transition. There's not a certification out there that teaches that. So check out the website, sign up for the wait list. Our fall cohort will be enrolling starting as early as June-ish, July. So make sure you are on the freaking wait list. In the meantime, be sure to check out the BirthFit community. This is a community built for coaches and practitioners and the mothers that want to do deep dives with us. Totally welcome. We have 4 live calls a month. The first call of the month is usually the deep dive. That's where we go head first into a particular subject matter. The next call, the second call of the month, is usually a guest speaker. The third call of the month is a movement class. This is a a mindset and movement class. For example, last week we did a little yoga flow-ish into a face lymph massage session. And then the fourth call of the month is office hours. Within this membership, you get 40% off all of our training programs, and you also get access to our growing resource library. So, for instance, today I'm talking about cervical dilation and effacement. Our next community call, we're actually talking about all four of the big whammies. So, station grading, Friedman's curve, cervical dilation, and effacement in a presentation, a deeper dive, and that recording will be inside of the resource library. The discussion, the deep dive I did last month was all about belly sleeping. That recording is inside of the resource library. So get in there. All right. Cervical dilation and effacement. The tools measuring labor progress are wrong more than half of the time. Let that sink in. And I hear so often about, oh, I didn't dilate or I didn't open or whatever. Like those two measurements, how the cervix dilates, how open is the cervix? Think about like a donut hole, like a donut, the hole in the donut, and then how thin it is. So the donut thinning, flattening. Those two measurements are treated as gold standards for assessing labor progress. They often determine hospital admission and whether labor gets augmented with Pitocin or something else. And then when a cesarean is considered, like just think about that. Those two things right there determine a lot. But what most providers won't tell you, because oftentimes informed consent is not happening inside of the hospital or even inside of some birth centers. Um, what they won't tell you is both measurements are highly subjective, inconsistent, and inaccurate. So let's think about that. How is dilation measured? Well, a provider inserts two fingers into a woman's vagina and estimates the diameter of the cervical opening based on how far they can spread their fingers apart. Let that sink in. There's no ruler, there's no measuring device they insert. It's just the fingertips, palpation and estimation. So hopefully you're catching on, like, okay, I already see a problem with this, right? Everyone's fingers are different sizes. If one doula or one mom measured using her own index and middle fingers combined, she might find more than 2 centimeters, maybe because she has small hands. Um, as compared to a male provider, he might have bigger hands. So, multiple studies have demonstrated just how subjective the dilation measurement really is. Only 19% of experienced clinicians' measurements were correct in a study. Um, and then when tested on soft cervical simulation models, that's what they were testing in this study, which are designed to replicate real conditions. But only 19% of them were correct. So the other thing, two examiners performing a vaginal examination during labor have they had complete agreement on only 42 to 49% of the cases. That means they disagreed more than 50% of the time. I will point out, but they were in agreement with about 1 centimeter for about 90%. But if you think about that, when a woman's told she's 5 centimeters and another provider tells her she's 6 centimeters or 4 centimeters, if she's having three different people check her, that's a lot. And then oftentimes some of the hospital admissions based on, oh, you got to be 6 centimeters. So just something to think about. Another study of 188 women in active labor found a mean error of 10.2 plus or minus 8.4 millimeters when digital examination was compared to position tracking verification. So what the translation is, two providers examining the same woman at the same time can differ by 1 to 2 centimeters. And clinical decisions, admission, augmentation, cesarean, all that, right, still hinges on this. Okay, let's talk about effacement. This is even worse because cervical effacement is the only component of a cervical exam that does not have a point of reference. Like there's no consensus on a baseline cervical length before labor begins. Williams Obstetrics says 2 centimeters. Ultrasound studies show 3.5 to 4 centimeters at 24 to 48 weeks, and 3.0 to 3.5 after 32 weeks. So as you can see, it's kind of all over the place. Without an agreed upon baseline, how can a provider accurately estimate what 50% effaced means or what 80% effaced means? I would say they can't. So, one study concluded very bluntly the traditional method of reporting cervical effacement as a percentage is unacceptably inaccurate compared to actual cervical length determined by a vaginal probe ultrasound. And nobody wants a vaginal probe ultrasound. So, the lack of evidence for routine checks. Let's talk about that. Despite how central cervical exams are to labor management, right? If you go into the hospital, there are protocols and procedures, and a cervical exam is right up there in the center of it. A 2021 Cochrane review found insufficient data to assess whether routine vaginal exams actually improve outcomes. A 2014 systematic review found routine checks don't predict when labor will start and can cause unnecessary intervention. The World Health Organization, recommends avoiding vaginal exams during the first stage of labor unless there is specific indication. And the risk? So, y'all, vaginal exams come with risk. And this was really surprising for me when I first started out as a doula. Because to me, it was like common sense. Like if somebody's sticking their fingers in your vagina, even with gloves, y'all, there is a possibility of infection. You want things coming out, not in. Um, so yes, there's a risk of infection. And that risk of infection, that's a whole other podcast, but it will vary from person to person based on everything that's going on. So the other risk, psychological harm, especially for those that are trauma survivors, and the risk of unnecessary intervention based on misdiagnosis, such as slow progress, failure to progress, whatever, you know? Um, so if you are a coach or a practitioner or somebody that is serving women inside of the motherhood transition, what do you do? Well, you help her understand this. For instance, you help her understand that if 5 centimeters could be 6 centimeters with a different examiner. You also help her understand that, okay, maybe she was laboring at home and it was a home birth that transferred to the hospital. She got to the hospital and she was a lot less than what her midwife said. Well, also, when you transfer to the hospital, there's a different person doing a vaginal exam. Also, your nervous system is basically telling your body, okay, we've moved locations, you're in the car. Now might not be the best time to birth. So we're going to work on survival rather than reproduction. So it starts to halt and stop labor. Um, Help your clients understand that slow progress is still progress. And also, like sometimes the first stage, so like prior to 6 centimeters, takes a little bit. And that's totally normal. Um, the last thing I would say in this is these are just a snapshot and a moment of time. The cervical measurements are outcomes of labor. They're not causes. Um, they're just stating what is at that particular moment. Um, so start to ask questions, you know. Maybe before getting a vaginal exam, you teach your client, your patient, hey, why don't you ask Why, why, why are we having to do a vaginal exam right now? I want to know the why before I say yes or no to this vaginal exam. And then if I say yes, will the results change the course of care, the plan of care? Because if it's not going to change your plan of action, then why do it? And then always asking, can we wait a little bit? If there's time to do a vaginal exam, it's not an emergency. All right. So what if we, I want you to think about this. Listen, especially if you listen to the previous episode about station grading and Friedman's curve, and now we just chatted briefly about dilation and effacement. If you took all of those away, how would you know that labor is progressing? Well, what have traditional midwives done all along? They've looked at the emotional signs and symptoms that women give off, the vocalizations. They look at the purple line on the booty, and they observe the woman as a whole. And like I'm saying this and moving my hands and closing my eyes, but you can tell when a woman has basically left Earth and gone to another portal um, to bring her baby Earthside. If she's still having full-blown sentences, she's at the beginning of labor, right? If she can only say one word or two words at a time, she's progressing. If she says things like, I feel like I need to poop, she's progressing. She might really need to poop, but also that might be the baby's head. So the bottom line, cervical dilation and effacement are not inherently harmful measurements. Like I've said this on previous podcasts, like the people that created them, their intentions were probably well-meaning. And I really believe they came from a place of good, like trying to support women. But now they're treated as absolute certainty. Um, and clinical decisions are made on these tools, these labor grading tools that are inaccurate more than half the time. And that's what causes real harm. So your job is to hold these tools and the people that use these tools um, I don't want to say accountable, but hold these tools loosely and have conversations with your clients, support them in asking better questions to their care providers at the time, and sprinkle in some birth education here and there. And especially if you're a doula or a midwife or you're attending and observing and witnessing labor, never let a cervical number, dilation, or effacement override what the body is showing you. Um, I think that's really important. So, as I said, we talk about things like this and a lot more inside of the BirthFit community. Check out that membership and then be sure to check out the website, sign up for the waitlist for the BirthFit certification happening this fall. All right. Peace, y'all. See you on the next episode.